Uh, Hello, dear colleagues. My name is Mynzhylky Berdikhojayev, and we are from Almaty Presidential Hospital. This is a patient number 1 for today. Patient 48 years old, previously treated AVM from the splenium of the corpus callosum, and with deep venous drainage, and it was complete occlusion at that time. But 14 years later, it was done in 2010, and now we can see some remaining AVM. Patient has headaches. That's why he did a control MR, and on control MR, this AVM was found with deep venous drainage from the ACA territory. And I think this branch will go to the AVM. We will do transarterial approach, and then if the vein will be clear, we will go transvenously. But I think we can do it transarterially. It's on the plane A. We can see there is it's a very slow flow, and maybe this one is going there. Yes, and maybe transarterial embolization will be possible. Окей. Пока надо будет на общий вид перекинуться, Жень. Ром. Есть, да? Just a second, I will... Теперь можно будет показать еще раз. Окей. It was done before. Just a CT. Okay. Okay. My colleagues did some clearing of the system, and it was only supply from the ACA territory, and there is a good peak home, and it was nothing from the posterior circulation. We can check with microcatheter if it's needed. We can go from the PCOM to PCA, and we can do angio, but it was clear. Okay. I will just check on my telephone. Just a second. Yes, this is a... No, it's not this. It's not this. November. Okay. Рауан, задний мозговой нәрсе жоқ деді? Жоқ, қазір. Хотя бір кіріп істейсаш. Бұл жыртылмаған, да? Okay. Yes, it was bleeding in 2010, and at that time patient was treated at the time of bleeding. Maybe that's why it's recanalization. Okay, and today I'm happy. I'm happy we have a gravity cover, and I can do many cases. Okay, let's start. Пока позвоночек бір қарай сал. Так, Бақыт, headway duo келді ма?
Headway duo бар.
167 деген бар ма? Headway duo 167. Ой, хорошо. Ладно. Жоқ, нені бере салсы. Соник 1D235 деген бар ма? Соны аша беріңіз. Аха, и ненің 2 шприцін ашып сайсыз қой? Сквиттің 2 шприцін. It's okay. 1D235. Все, осыны аша беріңіз. Okay, we have no 1.2 Sonic, we have only 1.5. Okay, let's work with 1.5. It's the end of the year, and in this hospital we have remaining nearly 20 cases, and then we will finish this year. And after that will be only private cases. Demonstration. It's a dimethyl sulfoxide. Son iki nasze wynoszenie. Okay. Now you can see the angiography from the vertebral basilar system. And there is no supply for the AVM, and yes, the supply from only PCA territory. Okay, this is dimethyl sulfoxide, and this is for Menox or squid. There is no problem if we will mix. Your name is Shailen
Nayak.
Shailen
Singh Nayak. Shailendra Singh Nayak.
Shailenger Singh Nayak. And short version?
Nayak.
Nayak. Okay. Today we have our guest doctor Nayak from Hyderabad. He just arrived at midnight, and yes, you came for 2 weeks, yeah?
So 10 days.
10 days, okay. 10 days. This weekend and next weekend?
Yes.
Okay. It's good, because after that we will finish all budget.
Yeah.
And then it will be less cases in this hospital. It's like a Christmas holidays, huh? Okay. Okay. I will put it here. Yes, and I have sterile cover for my zero gravity system, and today it will be more comfortable to work in this operating room. Кондиционер 22 қоя салыңыз. Бақыт. Еркес. Кондиционер 22 қоя салыңыз. Okay, we are flushing everything. For the next case, you can also scrub, okay?
Yes.
This is only available Sonic 1.5 35. Yeah, detachable length is 35. We found that 3 centimeter Apollo is quite comfortable, but in many places colleagues using 1.5, 15 millimeter, 1.5 centimeter detachable length, but for me 3 centimeter, 3.5 centimeter is more comfortable. And we using mostly this length. In some cases we are using 25. It's, I think the experience with the marathon recommendation was detachable reflux length
Okay.
should be 1.5 centimeter,
Okay.
because after 1.5 it's a little bit hard to detach the marathon.
Okay.
Yes, if it's reaching 2 centimeter, then it's impossible to detach. Huh? That's why I think it's a habit. But 3.5 also the experience from previous Apollo, the first detachable in our country was Apollo, and then we had a Sonic. Yes. That's why we're using 3.5 centimeter. Okay. No, is it?
Why are it hybrids?
With hybrid is coming in the box. It's a set.
Okay.
Hybrid is 8. With 1.5 it come with 8, and with the 1.2 there is a hybrid 7 inside. It's coming in a box, that's why it's no problem. But if you use two different Sonics, then you should know which one is 7, which one is 8. Okay, this is a zero gravity, and for each case we are using this sterile cover. It's a $50, but for this case government pays $12,000, and I think $50 is nearly nothing, and for me it's very comfortable.
Okay.
And Rawan is my assistant, and he's wearing the regular apron like this, and it's nearly from 5 to 10 kilos.
Yeah.
It's additional 10 kilos, and at the end of the day you have pain in your lumbar spine and the knees. Yeah? Okay. Okay. In 2010, this case was done with the marathon. Apollo detachable catheter came to Kazakhstan in 2013, 3 years later. Yes, and the first experience with the marathon was, I think, all first experience in Kazakhstan. I think in the world the same experience before the detachable microcatheter era. We have seen a lot of dissections and rupture during the marathon retrieval. Huh? And nowadays it's very comfortable when you have a Sonic and Apollo. Yes. But after coming detachable microcatheters, the next type of complication is venous occlusion. When you did very good penetration with the liquid embolic, and then you start to occlude the venous side. It's a second generation of complications. Yes, the first generation is dissection, and the second generation is the occlusion of the veins. Yeah. And also, when you have a longer detachable tip, it could be unnecessary embolization of the proximal part of the artery, and it's also causing the additional damage. Huh? Each material has own complication possibilities. Okay, it's a life. We need to pay some price for each advantage of the material. Okay, the guiding catheter is, the sheath is 7 French short sheath. I think it's a Teruma. And guiding catheter is 7 French Fubuki from Asahi. And my Y connector from Balt. I like these Y connectors. Yes, there is another type of Y connectors. this is merit Y connectors. It's also very comfortable with click,
Yeah.
1, 2, and it's possible to put 3, 4 devices and without leaking.
Okay.
But we used to use this one. It's also click, and the angle between this lateral hub is different. In bolt, it's more 30 degree. This is nearly 60 degree. Yes. That's why we can use two. This bolt. This is maybe Merit Medical, maybe some Chinese companies. They're copying everything. Eh?
Yeah.
Okay.
Fubuki ID is how much?
Fubuki 7 French. Internal diameter is inner diameter is 2.06 millimeter. Okay, with the Fubuki, it's possible to use two sonic and one headway duo. It's possible to use. Okay. Okay, there are small supply from Pedicolazole. Yes, we have this panel was damaged. This coming from the pedicolosal artery, and this coming from the callosal marginal. Yes, назад. And pedicolosal branch is small, and I think it's different sides. This pedicolosal, назад. This pedicolosal, наоборот, назад. Yes, I think this pedicolosal is from the contralateral side. Okay, and this is left side should be callosal marginal. Okay, let's check. Maybe the pedicolosal is coming. назад. Вперед. Назад. Маған периколозный көрсетші. Maybe pericallosal is coming separately, yeah? Назад. Stop. Okay, let's see from this point. Maybe it's coming something here. Okay? Smart mask. There is some spasm in proximal part. That's why I will take my guiding a little bit back and it's a complex cases, and at the complex cases we are putting the Surah Bakara. It's from Quran, huh? The music, and it's very helpful for the patient. Yes. Okay. Okay, till this point, and then we can go with sonic. We can do more less selective injection from here. Okay, let's check. Tampon verirсеш bana. We can put the Michael Jackson, but Surah is more calm situation. It's not annoying and тоже сломайка. Koyuyorsun. Oh, okay, the both feeders coming from here. Period. Yes, it's not callosum marginal, it's some perforating branch, and I think the angulation of this branch could be less. Okay, let's go to the bigger branch, and then maybe we may catch this territory retrogradely, because it should be a lot of brain here. Yes. But for the emergency, maybe we'll put second microcatheter there. Everything might happen, and we should be prepared for this situation. Okay. Okay. Now I'm pushing my microcatheter. It's more selective. Okay. Yes, we can occlude it retrogradely. Stop. Ага. Чуть-чуть назад. And назад is a little bit back. Listen. It looks like there are two veins. One is a deep vein, and the second vein is going to the sagittal sinus. Бақыт, екінші пациентті клейді аламыз ғой? Сол кезде шақырта бересіз.
Мочевой саласасын шығарып.
Я мочевой бәріне салады. It's very important to have a urine catheter. For more comfortable stay of the patient on the table, because after filling the bladder with the urine, and patients start moving all the time. Yes, after flying from Seoul, I had some cold. I caught a cold, and I had some laryngitis signs. But this time we usually cause some spasm. Okay, let's check. More distal position of the guiding is better. Now it could be a little bit dissection. Okay, let's see. Yes, it's like a bit of dissection. Okay. Okay, let's see. It's not occlusive. We will see. Okay. There is a bifurcation. Yes, 1.5 is a little bit stiffer than 1.2. Navigation is a little bit harder. This angulation is a little bit accurate, eh? Okay. I couldn't rotate my microcatheter. Okay, the proximal ICA is a little bit dissected because of this little bit tortuosity, but usually it's not problem. We will give heparin after. With no problem. Okay, period. Okay, now we occluded the main feeder, and let's check the angio. Yes, it's better to have 1.2. With 1.2, it's navigation is easier. Okay. I think it was a branch near, yes? It was the bifurcation, and some part of the bifurcation was taken. Okay. Let's go a little bit distal. Maybe we'll take regular headway 17 to place a couple of coils proximally. Unfortunately, we have no headway duo. Yes, for this kind of cases, it's better to have headway duo. Okay, more angulation. The angulation like this. Small. Oh, здорово. Дуже нормально. Бахет. Бахет. Кім бар? Шахмет. Қазір бір секунд. Пока еш нәрсе бермейді жатыр. Okay, there is a lot of angulations. Okay. Okay. There is U-turn, yeah? It's 360 degree, nearly. Okay, it will not go. Just a second. Has because some spasm. Okay, let's wait. Нима топ бар ма? Okay, there is a bifurcation here. Yes, we need to occlude here with coils. Шахмет, держишь? Здесь септор менее ворует, да? Gamma, HD17, and the shalom. тұрғаным 1.2.25. Ең астында. Соны ашып бересіңші. Okay, we have Sonic 1.225. Huh? That's why very important to check everything by yourself. Huh? It's a smaller Sonic. Açsa. İkincisi. İçinde daha var. Қағазын бере сал. Мына жаққа. Okay. Now it's better to have more smaller diameter. 8 құя сал. Okay. Так, на яким шатастрома. Так. Turkish please, huh?
Оно швидко выглядит.
Yes, now it could be a little bit complex to navigate this Sonic because of proximal dissection. Let's take this.
Aslında ela 8.
So, the second case will be stenosis, and case number 3. It's a patient previously treated at the time of last neuroadict in Astana with the callosal AVM, and it was on Sunday. We did that case together with Alberto and Rene, and Mario was also there. I think this one. No? Less navigable. I'll put it here. Okay, it's not possible. Okay, let's put it here. Абсцесс. Просто тартасал. Предыдущий не выходил, смартмаска. Okay, it went without any problem. Кирилл. Now we are in AC territory. We have been before, and that's why I know how it goes. Huh? Now we'll follow the first microcatheter. Okay, I will bring the first Sonic a little bit back to do navigation easier. Okay, let's leave it like this. Okay. We need to shape the microcatheter. What's here? Жана иңесин кийгиз. Yes, it's better to go distally. Then it's more comfortable to inject liquid embolic. Huh? Okay. What I learned from René, if you need a bigger angulation of the wire, just put the finger on the tip of the needle with the wire. He didn't say me do it like this. I just noticed it when he did it. Yeah? Okay, now we have more angulation. Then your angulation is more like pigtail, eh? Small pigtail. Okay. Okay, the wire is there. Yes, with all this tortuosity, the navigation could be a bit complex. Okay. Then it's better to have this shape. It doesn't want to go, huh? It's like a little bit spasms there. It doesn't want to go. It goes to the previous artery, huh? Okay. It's very soft part. Okay. It's a small artery, that's why I will put both microcatheters at the same position. Okay. Не верится. Демсо. Быстро. There is a little bit extravasation. Демсо тур сквит женесеш? Алайыр. It's all the time could be like this. No problem. Take the needle. Okay, we have time. Екіншісіне ине кигізбеш. Ине кигіз берсең. Да. Екінші проводник. Ага. Жоқ па? Все хорошо. Ладно. Давай. Сквит. Okay. Glue жасасыншы. It's a little bit subarach, but no problem. Okay. Now I need to pull my microcatheter a little bit. Exactly. Okay. It's okay, no problem. It's life, huh? It's not all the time easy. Huh? It's feeding from the proximal part, huh? Okay. There is a remaining part, but because of the flow we couldn't see it. Glue koydu mu? Glue koysunuz. Glue. Koymadı. Koymadı. Yes, now it's reached the detachable point. I will bring my first sonic approximately. Ah, it's detached, huh? Dexamethason 12 mg. It was detached because of all these manipulations. Yes, it's the remaining part, huh? Go. Жүрөз, Sony кажется. 1.2, 25. Ең астында жатыр. Ең астында жатыр. Эх. Now the reflux has reached the detachable point and I need to stop. We have a second branch and we can go from the second branch. It's also possible to stop from this point and to give time to patient. Huh? Okay. Мозгович. А внутренний сонный төменгі жағын диаметрін өлшеп жүрсаш?
Внутренний сонный диаметр төмен жағы.
Okay. Дефицит бар ма? Дефицит бар ма?
Дефицит жоқ.
Okay. Следующий. It looked like the first session of the treatment was done from the PCA territory. And then might be it was the same type of bleeding, maybe. And it was not reached the venous territory. It was just on the branch from the ACA. As the ruptured AVMs, usually there is no connection inside the AVM. Huh? That's why the most of the time it's complex to penetrate the distal territory. Okay, now it's going distally. We have time, we can continue. Yes, we opened the second sonic, and it's on the table. Now for the reflux at the between the first and second markers. Okay, let's wait. It tried to go distally. Yes. We will take the second sonic and put to the proximal branch. I have seen AVMs after gamma knife, but I hadn't patience after gamma knife for the embolization, just for observation. And I think after gamma knife it could be the same situation. It could be the occlusion inside the AVM. And then you couldn't reach from one artery to another. I think it's a possible scenario. Maybe soon we will have these patients. Because in Astana we have gamma knife since 2022. And now it's a time of accumulation of these patients and they will start bleeding. There is a rate of non-successful gamma knife treatment in maybe 30% of cases. From 10 to 40, 30. Okay, then that patients will come to us. Okay, somewhere here there is a branch. Okay, let's inject a little bit more. It's a normal branch. We need to occlude it to go distally. Okay. It's also the part of the reflux. Okay, now reflux is too proximal. I need to take it out. I don't need this one. Okay. Spitz retention sıkıyorsun. Hazır. Let's check. Okay. There are two options. We can finish from this point, or we can go to the branch and occlude the remaining part. It's like a collateral flow. Okay, let's see. Navigate koyarsa Ahmet. Yes, when you are dealing with AVM, you should be ready to occlude the artery, because it may cause big bleeding and then big problem. Yes, this branch. Yes, with 1.2 it's quite comfortable to go to this small branch. Huh? With 1.5 it's usually impossible. Okay, I can proceed a little bit more. Okay, now there is a angulation. Huh? Okay. I think there is a limit. Just a second. It should be the same 360 degree angulation. Squid pendulums on there.
Pendulum.
Okay.
Benim sağ.
Let's check. Yeah, it looks like we can proceed distally. Huh? Stop. Okay, we can try to go, but О, даже глюра инструмента пока. Типа то. Гибрид пересаж семерка. It was touched screen. Джоджо, гибрид семерка отдельно. Я мен даусым қарлығып тұр ғой содан ғой. Okay. Okay, I did a smaller angulation. We have small angulation and let's see how it will behave. It looks like there could be some branch or it's a vein. I think it's a vein, yeah?
Yeah.
It looks like vein, yeah. Okay. That's good. Smart mask. Stop. Smart mask. It's the advantage of the Philips system. I think on Siemens it's also available, but on Philips it's very comfortable. It's possible to push only button and okay. I think now we're distally. We are somewhere, huh? Okay, just a second. Just a second. There is one more angulation, huh? Here is one more angulation. It looks like the branch is bigger, huh? I think it's enough because the proximal part should be also detached. Huh? It's not only distal, but also we need to keep in mind the proximal part of the branch. Okay. Okay, now it looks like we're inside. Yes, it's a small branch. And let's go proximally. Now, Sheikh it. Sheikh met glura-reuzers. Sheikh it. Okay, quite distal. Glue koyup koydun mu Şeyh Ahmet?
Ахат гүлі қойды да шнекіне жоқ қазір.
Pedal basıp atқан жоқ mu? Енді бассашы. We're usually doing it from here, but the control panel was broken nearly. It was the second day of Alberto came here, and we did the first day. It was okay. The second day it was broken, and since that time it's not working. Huh? It's nearly 2 months now. We are waiting for the fixing this problem. Waiting for the fix. Okay. Now it would be like this. Okay. It's a wedge position of the microcatheter, and usually possible to inject deeply. Yeah? Yes, now the liquid embolic is arriving. There is a reflux, reflux till the second marker. Huh? Okay. Let's wait. It's a short one, 25. But now there is no AVM. Eh? The both feeding branches was occluded. No AVM. It might be something, but yes, it might be something, the posterior circulation. It's quite small branch. And okay, let's try to occlude that part. Okay. A second. There's better. It's in the middle. It was smaller branch coming, and also the reflux. It's like a Tura injection, huh? Tuck, tuck, tuck, tuck, tuck. Small. There is a reflux. There is small reflux till the maybe second marker. Let's wait. It might be reflux, but I'm not sure. It might be reflux, huh? Might be. It's badly visible, but okay, let's see. Yes, it's better to finish from this point, huh? Yeah, it's going forward. I'm not sure, but it looks like there is a reflux, huh? I'm not sure, but it looks like the reflux. This one looks like the reflux. I think it's better to stop. I'm not sure, but yes, there is a reflux. Yes. Okay. Let's do one more injection and maybe then we can stop. Yes, if we will have problem with detachment, we can cut the microcatheter inside the groin, at the groin, and we can leave it there. It's very hardly visible, but I think it was the reflux. Yes, it looks like it's a reflux. I'm not sure, could we detach this sonic? Maybe it's better to leave it there. Huh? Okay, now it's maximum. Okay. It's maximum tension. Okay, let's wait. Let's wait. This looks like reflux, huh? Okay. Okay, let's finish. We'll wait for 10-15 minutes. And if it's not detached, then we can leave it there. Huh? Yeah, it's very hardly visible reflux. Yes, A1 is with spasm. It might be small remnant from the PCA territory. Small choroidal branch may go there. Period? Period? Yes, but very slow flow. Okay. Timer where надо было? Okay, I will release the sonic. It was not visible, huh? I think it's stuck. Yes, it looks like it's stuck. Yes, it's tension. Okay. Let's wait another 5 minutes and then we can see. I think the city is better at the end, huh? Maybe in such cases it's better to do with glue. As Rahul Kumar is doing it all AVM cases with glue and he showed very good results. Huh?
Glue we can concentrate.
Yes, we can do less concentration with the better penetration and then you can easily take it out. And it's all the time short reflux. Huh? But I have seen one major complication. It was a thalamic region AVM, and we did a concentration 25%. And we injected the glue, and we occluded part of the nidus, and little piece went to the venous part. We said, okay, vein is open and it should be no problem. We ended the case and after 2-3 hours it was a huge hematoma. We took patient for the angiography and this small piece of glue became 3 times more larger, and it thrombosis with very hard clot the venous portion, and we tried to go transvenously, and the microcatheter couldn't proceed the glue. It's also the possible complication from glue. Each material has own possible complications. Okay, we have sterile seizures. Is it correct to say seizures, yes?
Yes.
Seizures, okay. The same epileptic seizures, yes?
No.
No.
That is spelling is different.
Spelling different.
That is Caesar. This is Caesar. S and Z.
Okay. But in Kazakh language, this is seizure and epileptic seizure. Okay, it's a seizure. Okay. It's like a beach and beach, eh? There's a beach at the seaside and there is beach. Eh? It's very complex English language. Eh? Yes. But the same with Kazakh language. The head in Kazakh language will be bas.
Bus.
Bas.
Bus.
Bas, yes. And head of the department would be bas. Bas. Basha. And to press, it will be the same bus. Bus. Yes. I think in every language they have
Yeah.
homonym, we say, yes? It's homonyms. Okay, it's 6 minutes and it's not going to be detached. Okay, I will release a little bit and then we'll try again. No, it's quite a big reflux and it will not detach. Okay, then it's possible to damage. We don't need to harm the patient. That's why we will end with this microcatheter inside the artery. Okay, after control CT we will give heparin to patient. Okay. Okay, to do this we need to cut. It's a standard procedure. Okay. Okay, now we are in the common carotid. It's quite risky to do angiography because it might flash the guiding catheter into the aorta. Okay, no problem. There is no tension and the brain looks normal. Okay, it's like this. Now, okay. Now I will control the tension. Okay. I think it's maximum tension. Then we cut it and introduce Miss Birser. Хвинесі бар ғой, итеретін ішінде. Бұл же, бар ма? Okay. I have seen one complication from somewhere, yeah? Somewhere. And after cutting the microcatheter, it was a angiography done. It was forcefully done, and all microcatheter was in aorta. Yes, it was from some place, but you should keep in mind that such a complication possible. Okay, I'm not sure we need to go there. Now we need to check the groin. If groin is okay, then we will take out the after 3 hours, because all this action, yes, it's inside the artery, no problem. Yes. Okay.
Bakın. Sistem nasıl kalmış?
Okay.
Anladım. Tamam.
Қазір 1 секунд. Қазір КТ-дан кейін 3000 жасай саламыз. Қазір КТ жасайық. Okay, let's check the CT, and after CT we can say everything is okay. Қазір 1 секунд. First of all, we will check the groin.
Bakın.
Yeah, it looks like it's outside. Yes, it's outside. Okay. Now we'll put for the CT. Introduce какой-то сразу, хорошо? Джо, МРТ через 3 месяца. МРТ через 3, контроль через ангиография через 6. Каската, господи. Okay. Now we'll wait for the CT. Okay, let's go. Oh, Саш. Okay, let's put CT. Травис. We put cerebral CT, and with the CT, 5 seconds. Все, господин. Показывай. Okay, dear colleagues, CT is ready. There is a lot of artifacts, but yes, it's downstairs. Downstairs is normal. This is a liquid embolic, and it was slight subarachnoid hemorrhage, but no problem. And yes, we can extubate the patient, and it shouldn't be any problem. Okay, this is liquid embolic, and this is microcatheter. Okay. Okay, see you in next 20 minutes. Next case is stenosis, and today we are planning to do 3 brain AVM, several brain aneurysms, and 3-4 stenosis. And also we have hemangioma, vertebroplasty in a single monoplane operating room. And okay, see you in 20 minutes. Thank you. So, гепарин.